So I'm Brian, and by show of hands, who was here last week? Okay, most of you. Great. So it was planned for me to come back, so thank you for having me back. The last week's talk was about the use of opioids, but this talk is about opioid use disorder, other substance use disorders, and implications for dental practice. So last week's talk had more to do with pain management, and this week's talk had to do with when you identify and how you identify somebody that has a substance use disorder, what role and what to do in dental practice. I should cover again that this talk has been funded through the State Targeted Response Technical Assistance Program, or STRTA. It's a program that's been funded through the Substance Abuse and Mental Health Services Administration, and it provides resources and technical assistance for providers, agencies, and entities across the United States that are interested in addressing the opioid crisis. The TA Consortium accepts requests for education and training resources, and there's a designated team led by a regional technology transfer specialist who is expert in implementing evidence-based practices. This is the website, this is the email address, and this is the phone number if anyone wants to get connected to the STR program. Okay, I have no conflicts of interest to disclose. I am not paid by any pharmaceutical companies or any other commercial interests. And what I was going to talk about today was just an introduction to addiction as a medical disorder. What most primary care physicians, and I've never been in dental practice, but what I'll sort of throw out an assumption that many people put substance use disorders as part of the social history, right? It's sort of habits so that somebody has. And I would suggest that it goes under the medical history, that addiction is a medical illness. It's a brain disease with developmental and learning disorder implications. To talk about the impact of that disease on family systems and community dynamics, to talk about screening and assessment tools for substance use disorders, to talk about a motivational interviewing adherence strategy, to evoke change from patients and their family members, and then to talk about when a substance use disorder is likely, not necessarily confirmed, not necessarily made, but when you think that somebody might have a substance use disorder, how to connect them to where to go next to maybe get a confirmatory assessment and some treatment. Okay, so this is a sagittal slice of the human brain. This is the back, this is the front, this is the top, this is the bottom, this is the brainstem. And there's some neurons in the middle part of the brain that go from a part of the ventral tegmentum to the nucleus accumbens, which is sort of located in this general area, although not in the midline. And the brain, as we know, is made up of neurons. So neurons with supportive cells called glial cells, and these neurons connect to each other. They connect to each other through neurotransmitters. So we have a cell transmitting information by releasing neurotransmitters into cells that receive it. And you can have an axon, which is the part of the neuron that communicates information, connect to all sorts of different parts of the brain. So it can connect to other neurons in multiple places, and it can send signals in multiple areas of the brain. So these are what we think of as localized circuits in the brain. So there's your occipital cortex, which is responsible for vision. A lot of human brain power is responsible for processing visual information. And coordination is in the cerebellum. You take out the cerebellum, people have a hard time walking and coordinating. And pain, which we talked about a bit about last time, are ascending circuits that go into the thalamus, and that's how we process pain information. And I want to, and then out as we go, and this is a two-dimensional image trying to render a three-dimensional structure, but we get memory that comes from the midline out into our hypothalamus, which is in our temporal lobe, and that's what that green structure is thought to represent. Reward, or pleasure, or when you get high, is mediated by one circuit. The dopamine circuits, that is the cells that release dopamine that leave the ventral tegmentum and project into the nucleus accumbens. So that's the part of the brain that receives dopamine. There's other parts of the brain that receive dopamine too, right? So the caudate and the putamen that are in the brain, they're huge centers for dopamine neurotransmission, thought to be responsible for movement. Dopamine neurotransmission also regulates prolactin hormones in our hypothalamus. That's not the dopamine neurotransmission I'm talking about. I am talking about the ventral tegmental to nucleus accumbens dopamine circuit. And the nucleus accumbens then projects onward into the frontal lobe, particularly what's called the prefrontal cortex, or this part of cortex right here that's in the very, very front. the prefrontal cortex is responsible for things like judgment, motivation, executive function, right? How to decide what to do where. And so when people have a substance use disorder, when they learn an addiction, when an addiction gets coded into this part of the brain, it recruits the part of the brain that are responsible for decision making. So for those of you that have ever taken care of somebody that has a really bad substance use disorder, and you say, I don't understand, the costs of using are so high, the benefits of using are so low, and yet you are using, that doesn't make sense. You are appealing to a part of the brain that has been impacted by this ventral tegmental dopamine circuit that is not behaving appropriately. So people sometimes call addiction a disease of motivation. People are applying their decision-making processes not towards things that are, I'd say, reflected in a dispassionate balance and analysis of the risks and benefits, but rather towards things that the brain says, get me more of that, and get me more of that as quickly as you can. So here's another sort of way of looking at this. Again, memory and learning, the amygdala and hippocampus, reward and salience from the ventral pallium and onto the nucleus accumbens, and then the orbital frontal cortex and prefrontal cortex, and the responsible for motivation and drive, anterior cingulate gyrus up there. So these parts of the brain that tell you, hey, calm down, don't go use, get turned relatively off, and the parts of the brain that say, go seek more stimulation, get turned relatively on. And that is the brain model behind addiction. This is how we understand addiction as a brain disease. This is just another way of demonstrating that same circuit, right? Ventral tegmentum, nucleus accumbens, prefrontal cortex. Okay, so in this context, human beings' brains develop over time. And over time, there's a brain at 20 weeks old, 35 weeks old. At 40 weeks, very young, we have a relatively well-formed cortex. It's not a mature cortex, but it's a cortex that over time begins to look kind of just externally a bit like an adult brain. It's smaller, but it's got a lot of the general sulci and the grooves that we typically see in an adult brain. And in adolescence in particular, the parts of the brain that are responsible for pleasure seeking and fleeing from painful things are more developed than the prefrontal cortex part of the brain that's responsible for balancing out those drives. So this is just kind of a developmental chart. In infancy, from birth, we get, people learn how to see, hear, and touch. We learn cue conditioning and implicit learning, like don't touch that hot thing, don't grab a bee, stuff like that. Right? We learn that pretty early on. And then hippocampus dependent learning gives us object placement, place preference, space preference. We learn how to navigate the world. And then higher cognitive function really kind of emerges in later childhood and into adolescence, where people are able to do higher order, say, decision-making processes. And so between the ages of 12 and 19, the parietal lobe is mature. We're able to see and process our environment in a relatively sophisticated way. The corpus callosum that connects the two parts of the hemispheres is now well developed and connected to each other. So we can process information between our hemispheres in a relatively mature way. Our amygdala matures earlier than our prefrontal cortex, and our synapses are adult density. But the part of our brain that regulates all of these drives, again, is relatively less developed. And we see between the ages of 18 and even 25, our frontal lobe continuing to mature. So for those of you that interact with, say, 20-year-olds, and you think, why are you behaving in such an immature way? A lot of it has to do with we continue to do learning up through age 25. And this is, again, a different kind of sensitive period in looking at brain development for human beings. We see, ages 1 through 3, brain development skyrockets, peaks really in between the ages of 2 and 12, and then we see ongoing brain development, but at a less rapid clip, kind of up through 25. And that's also between the ages of 12 and 25 is when we see the rise in sex hormones, right? Testosterone, estrogen, progesterone, luteinizing hormone, follicular stimulating hormone, all of the gonadal hormones. And we see regional peak and declines in synapse, neuromodulators, neurotrophins, and cerebral blood flow. Okay, so what happens when you introduce a substance of abuse to somebody whose brain is under development? The short answer is all of this myelination, all of these synapses that are always sort of being pruned, and the brain development that happens gets halted a bit. And not only does it get halted, but it gets reoriented around that substance. So oftentimes, I'll be working with a 30-year-old or 40-year-old, and I ask, when did you start drinking or smoking or using or whatever, when did you start using intoxicants? And they'll say, I don't know, like 12. I'm like, huh. Because it feels like I'm talking to a 12-year-old. Even though you might be in your 30s or 40s, right? Like the parts of your brain that helped evaluate things and make decisions and make, process and do executive function seems to not be working like it would have been had you not been exposed to an intoxicant at developmentally sensitive periods of time. So we have the striatum, we have the amygdala. Amygdala reacts to threats. The striatum pursues positives, and the prefrontal cortex that's responsible for mediating that is less developed. So if you've ever worked with an adolescent and you say, weren't you thinking, or what were you thinking? The answer is, well, the parts of the brain that help them think are less developed. So within this context, I tried to pull up a list of everything that I could find that could get you high, that can get somebody intoxicated. And there's a website called Erowid.com that if you ever want to look up, this Erowid's a great example of like, if you just had a website where people posted everything in the world that ever got them high, that would be the site. It is not peer-reviewed. It is not curated. It is just a repository. So you see things that you wouldn't, like mint, for example. Somebody talked about how they tripped out on mint one time. Sage, frogs, toads. You get a lot of things. So given the diversity of things that could possibly be intoxicating, addiction medicine, and really kind of, I'd say medicine in general, has categorized intoxicants into substances. And these are the substance categories that we think of as the major intoxicating substances. And these substances are associated with specific neurotransmitter systems. So alcohol is, well, I'll start with tobacco. Tobacco hits nicotinic acetylcholine receptors. Cannabis binds to enantiomide receptors, but we didn't discover enantiomide until after we had already named them cannabinoid receptors. So they're called CB1 receptors, that the native ligand is enantiomide. Benzos and barbiturates bind to GABA. Opioids bind to the mu-opioid receptor. Stimulants affect both dopamine and norepinephrine. Hallucinogens are usually serotonergic. And then alcohol is the most promiscuous of them all. Alcohol affects most receptor systems. Because if you think about ethanol is really just a methyl group with an oxygen atom. And so you see that ethanol affects GABA, glutamate, dopamine, norepinephrine, and serotonin. And you might say, wait a minute, you just told me that dopamine is the final common pathway, but these seem to affect all of these neurotransmitter systems. All of these neurotransmitter systems are connected either directly or indirectly to the dopamine system. So all of these substances increase dopamine neurotransmission in the brain, with one small caveat: hallucinogens don't uniformly cause increases in dopamine neurotransmission. So of these, hallucinogens tend to be the less addictive, what are thought of classically addictive. Not that they can't be addictive, but they don't always follow that common pathway. Everything else does. Question?
The question begs, which one is the most easily addictive?
So the question is, which is the most easily addictive substance? And I have a slide on that. So if I don't answer that question further in the talk, let's talk. All right. So the chance of developing a substance use disorder to which of the following substances is highest? Tobacco, alcohol, cocaine, cannabis, or methylene deoxymethamphetamine? So who thinks it's A? Who thinks it's B? Who thinks it's C? Okay, a couple cocaine. Who thinks it's D? Nobody. And who thinks it's MDMA? All right, okay. Great question. So what is the most addictive has just as much to do with the neurochemistry of the molecule as the set and the setting in which it's used. So I'll give you an example to try to illustrate this. Tobacco has been around for a long time, grown in North America for a long time. And indigenous communities used to take tobacco, dry it, and then as part of a structured religious ceremony, smoke it. And so even with young people that might pass the pipe around and take some inhalations of the smoke that comes from a burnt tobacco leaf, the incidence of tobacco addiction in that context is actually relatively low. Contrast that to an industry that dries out tobacco leaves, packages them in easy-to-handle cigarettes that are then sold 20 a pack, mass-marketed, so that not only do you use tobacco like when you're celebrating, use tobacco when you're stressed out, use tobacco when you wake up, use tobacco before you go to sleep, use tobacco when you have coffee, use tobacco when you're on a break, use tobacco when you when you're drinking, use tobacco when you're bored, use tobacco when you're with somebody, use tobacco to connect to people. Those settings of using the same molecule, the very same nicotine is in these tobacco leaves, but the context in which they're used is very different. So the coca plant and the coca leaves that have cocaine in them are themselves, hanging from trees in many parts of South America. But we don't see the additivity of cocaine until the cocaine is extracted and either put into a free base format, which we call crack, which is a solidified version, or into a powder cocaine, where it has a salt mixed in it, right? So the set and the setting of the use of these substances is different. So I'll just point out, this is the study, Probability and Predictors of Transition from First Use to Dependence of Nicotine, Alcohol, Cannabis, and Cocaine. Results from the NESARC. This is the National Epidemiologic Survey of Alcohol and Related Conditions. And let me be very clear about what this study is. This study looked at, of people that used a substance, were exposed to a substance one or more times, how many people over the course of their lifetime were then to develop a substance use disorder on that substance. So I don't mean what's the percentage at a given time of the users of that substance have a substance use disorder. What this is what's the chance that over the course of somebody's lifetime they would develop a substance use disorder on that substance at any given time, not just at the point of their first use. So this is not what's the percentage of users of this substance have a substance use disorder. These percentages are what's the rate at which somebody might develop a substance use disorder on that substance after they were exposed to it for the first time. Cannabis has about a 9% lifetime risk of use disorder. So it's not non-addictive, but it's also not uniformly addictive. There's a lot of people that smoke cannabis that do not have a cannabis use disorder. Cocaine is about 21%. Alcohol, 23%, right? Now there's a lot more people that use alcohol than cocaine. So cocaine, the molecule itself, is more addictive, right? I don't mean to say the chemistry isn't important. The chemistry is important. But tobacco, 2/3 of people that smoke over the course of their lives are going to develop a tobacco use disorder. And I think it's because it's legal, and it's because it's been historically highly reinforced. Now, we're in a period of time where a lot of the public health messaging has really driven down the rates of tobacco usage. But the lesson from this, for me, is less how do these medicines work, or how do these drugs work chemically, right? And much more so, in which context are they used? Because if they're promulgated and used widely, we're going to see more addiction. And if they're used, because in parts of the world where it's illegal to drink, very low rates of alcohol addiction, right? Prohibition, largely considered in the United States to be a, a political failure. And I'm not arguing for or against prohibition, but it largely seen as a mistake, drove down alcohol use disorder rates by like 2/3. So there is a public health argument for things like prohibition. I'm not making that argument, but I'm just pointing out the setting of the use of substances has a very direct effect on their addiction. So a couple things. The opioid epidemic, when we see very aggressive rates of opioid prescription in response to things like pain is the fifth vital sign, we always have to treat it, and the unspoken message, and we always have to treat it with opioids. And if somebody continues to say they have pain, we're going to increase the dose. And we're just going to, flood the system with prescription opioids. There's a lot more people with opioid use disorder in response to that kind of exposure. And we're seeing a big rise in the availability of cannabis. So one of my hypotheses is we might see this number go up. Now, is it going to be the same as cocaine or as tobacco? I don't know. But I do know that I would expect the more a population is exposed to substances, the more likely they are to learn, for the brain to become disordered and for them to develop a use disorder. Question in the back? So the question is, so when people talk about an addictive gene, are you saying that the risk for addiction is uniform across the population? Are there certain people who are going to develop a substance use disorder? Or what's the interplay between genetic vulnerability and vulnerability to addiction? Yep. So the comment was, so for example, if I had a traumatic injury and I was prescribed a supply of, say, 50 oxycodone, or oxycodone long-acting, which is OxyContin, then what, you know, how would that play with addiction? Because I wouldn't use all 50 pills. I would use it only as far as I needed it, and then I would go on to a non-opioid for pain control. So there's a couple things. One thing is that the vulnerability for addiction is not uniform, but it's also not always predictable. So it is impossible to know before somebody's exposed to a substance whether or not they're at risk for developing a use disorder on that substance.
So there's no test that somebody can take for, there's no DNA strand?
The question is there any genetic test for addiction? The answer is no. The best predictor of, so we do know for alcohol use disorder, which has been the most characterized use disorder at this point, for alcohol use disorder, the genes are relatively well characterized, but they're not characterized enough to run a genetic test on them. So we know like the locuses where they are, but we don't know all of the specific polymorphisms that are at risk. So we can't test for them, but we have a general idea of where the genes for alcohol use disorder lie. They're in multiple places. So it's not one. So in other words, people have what I think is best described by Mark Shuckett, who does a lot of this work at UCSD, is variable levels of loading, right? And so there are people that, so the best clinical tool I would suggest in evaluating somebody's genetic vulnerability for a substance use disorder is asking about their family history. And it's thought that genetics explain about 50% of the variance we see in alcohol use disorder. So that's not uniform, right? But that means that about 50% of people with alcohol use disorder have some family history that can help support their vulnerability to alcohol use disorder. And you can do genetic tracers in families to see which are the genes that were passed on to get some idea of what's the genetic loading. It's not too far off from cancer, right? So the way that we think cancer works is there's some genetic vulnerability and usually different types of environmental vulnerabilities. So one environmental vulnerability would be something like you got exposed to UV rays or other types of, or radiation, right? Another thing is there's carcinogenic chemicals that you could be exposed to that increase your risk, and then your immune system doesn't catch up with the sort of neoplastic division of cells, and then you develop a cancer. That's the thought. With addiction, the way that I would put it together is there's certainly a genetic risk. We know that for alcohol, and we think that's true for most other substance use disorders. But that gene doesn't explain whether or not you become addicted. You've got to be exposed to the substance, and not just exposed, but exposed over a sufficient duration in a sufficient way to then learn that use disorder. And then the third thing is typically there has to be some vulnerability in the use of other skills that somebody does not have the skills to manage whatever they were going to manage without the use of that substance. So those are the three ways that I put it together. Yes, there's a genetic risk. There's some people that can't tolerate the use of substances, right? They take it and they don't feel like they might have an aversive reaction. There's certain people that take opiates, they're nauseous, they kind of feel out of it, and they don't like it. Those people are almost certainly not going to develop a use disorder. But there's about a third of the population that really likes opioids, that they take them, and even if they're in pain, they're like, yeah, I took it for pain, but woo, I felt energy, I felt brighter, I felt better, I felt not depressed, I felt great. Those are people, that doesn't mean you're going to develop a use disorder, but that means that you're now at risk, right? You now have some vulnerability for then going on to develop a use disorder if opioids make you feel really good. And then you have to have the vulnerability of then your life being arranged such that you're not then going off to do other things instead of using substances. So you might say, hey, I took an opiate, I felt really good, but you know what also felt really good? Like playing sports, or my relationship with my loved one, or some other some other alternative to the use disorder that kept you protected. So I think there's social vulnerability, there's individual genetic vulnerability, and then there's exposure to the substance. And that's why I don't talk about there being an addiction gene or addictive personalities, because anybody has some vulnerability in theory, right? Until we test all possible intoxicants, it's tough to know what you could or could not get addicted to. So the best strategy of mitigating that risk is reducing risk of exposure to intoxicants, and even if someone is going to get exposed, to develop a really full life such that whatever draw that intoxicant has is balanced out by the other things that are going on in your life that make the use of that substance less tenable. Does that make sense? Yeah. Question in the back. So the question is, what about the pharmacokinetic effects on these substances? Isn't there individual variability in how people metabolize things like alcohol or cocaine or opioids, and wouldn't that have an impact on the addictivity of the substances? So the most addictive substances are the substances that are quick on and quick off. So the most addictive way that one could possibly use a substance is to smoke it, because when you smoke it, it goes into your pulmonary vasculature, right then into your left ventricle, boom, right up to the brain, right? It's the shortest loop. And then the next way would be you inject it, because you bypass all the first pass metabolism, goes right into your venous bloodstream, but then you have to go through the right ventricle, or right atrium ventricle, then into pulmonary vasculature, then into your left ventricle. So it takes a little longer to metabolize that, or to be absorbed that way. So things that are quick on tend to be more addictive than things that are slow on. Now, it doesn't mean that things that are slow on aren't addictive. It just means they're less addictive. The faster it comes off, the more addictive it is. So to relate that to specific medications, intravenous morphine, quite addictive, right? Because it's relatively quickly metabolized. Now, MS Contin, right, which is a longer acting version, is thought to be somewhat less addictive than, say, intravenous administered short-acting morphine, because it lasts longer. I use benzodiazepines in my practice. So alprazolam, which is Xanax, tends to be very fast on and very fast off. So people are using it, and they're learning to use it more regularly, and they're giving their brain repeated exposures, activating that dopamine circuit to the point where in some people they shift, right? They shift from using it appropriately to now beginning to rely on it and using it less appropriately. Longer acting benzodiazepines that have a slower onset of duration, like clonazepam, are thought to be overall less addictive. Now that said, there's plenty of people who have a clonazepam use disorder. I'm not saying it's not an addictive substance, but I'm saying the addictivity of the substances has to do with the speed in which it's on and the speed in which it's off. So there are absolutely genetic variability in how we metabolize all of these substances. The most common one that's notoriously talked about is there are members of the Asian diaspora who have lower amounts of both alcohol and aldehyde dehydrogenase. And famously, if you don't have aldehyde dehydrogenase in your body, you begin to build up acetaldehyde after you drink alcohol. And acetaldehyde is toxic. It changes your blood pressure, you get flushed, you get really sick. And so there are people that famously can't metabolize alcohol, like appropriately, right? And so they can tolerate either very little amounts of alcohol or no alcohol at all. Those people have very low rates of alcohol use disorder because it's hard for them to drink it, right? But not everybody in the Asian diaspora has that genetic vulnerability. And so that's not a uniform statement towards any particular what's called ethnic haplotype. It's more what we see a predominance of a certain variation in the way that that particular genes are expressed. So I'm going to get into some epidemiology now. We know among 12th graders who are housed, because this is from the Monitoring the Future survey, so it's a household survey by telephone, so it's kids that live in homes, that kids are reporting less and less use of Vicodin in particular between 2012 and 2016, from 7% to 3%. Now, I still want to point out that's still 7% of kids that say that they got exposed to Vicodin through some mechanism. And in this case, it's misuse of Vicodin. So this is not Vicodin that was prescribed for a medical indication. This is people that played around with Vicodin. And so to the point that was made earlier, let's say somebody was prescribed 50 tablets of oxycodone or long-acting OxyContin. And let's say this person only used 10 of them, hypothetically, right? That 40 pills or tablets of OxyContin or oxycodone that sits in the medicine cabinet waiting for an enterprising young person or family friend, or maybe somebody's coming by to work on your house and finds their way to the medicine cabinet. I used to treat a house painter who used to go into homes and look at medicine cabinets. Having unused opioids available has a public health effect, right? Because when you have in the world more opiates than you think somebody's going to need, those opiates can find their way through many different mechanisms towards people that are at risk of having an opiate use disorder. So there is still a public health effect to having unneeded opiates around, which is one of the importance of safe drug disposal programs. So right now the current recommendation is if you have medications that you don't need, don't flush them down the toilet, but crush them with coffee in kitty litter or coffee grounds or in dirt, and then discard them, because the grounded medications with something like kitty litter or coffee grounds or dirt makes them effectively unusable. We see misuse of prescription and over-the-counter drugs. Amphetamines are at 6%, tranquilizers are at 5%, opioids other than heroin are at 4.8% across 12th graders. Cough medicine is at 4% and sedatives at 3%, sedative things like benzodiazepines or barbiturates. About a little over a third of all 12th graders report past year use of marijuana or cannabis product. And then 4.3% hallucinogens, synthetic marijuana, MDMA, which is ecstasy, cocaine of any form that could be crack or powder, salvia, which is a hallucinogen, and then inhalants, things like nitrous oxide or whippets. So this is, again, Monitoring the Future survey looking at use of narcotics other than heroin in the past 12 months. And we saw a pretty big, part of this had to do with the way that they counted it. But any narcotics other than heroin in the past 12 months had a pretty big spike. Again, not part of that was the way that they asked the questions between 1999 and 2001. And then people saying the availability of narcotics other than heroin is fairly easy and easy to get is in like the 40 percentile range. And this is for red's 12th grade, blue is 10th grade, and green is 8th grade. So the more available a substance is, right, the more addictive it can be. OxyContin, or long-acting oxycodone use. Again, this question was added in 2001, and we see somewhere around 4% of children have reported using OxyContin for a reason other than prescribed within the past year. And Vicodin use, again, has dropped pretty significantly, but it went from, 9-ish, 10% down in 12th graders down to about 2%. And then people saying they're using heroin, we see lower percentages. So among 12th graders, we saw kind of a spike in the 90s as we were seeing a big rise in prescription opioids. That also, the more prescription opiates are available, the more people tend to transition when they stop using prescription opiates onto heroin for economic reasons. We saw more heroin available and used by high school kids. And then people that say that they see using great risk in using heroin once or twice has stayed relatively constant at about 60% among 8th and 12th graders, and for whatever reason the 10th graders say it was risk. From their 70% saw that they saw great risk. Heroin disapproval remains pretty high. It's not a socially accepted drug. And the availability, people have reported, again, during the mid-90s, greater rates of availability. Greater numbers of kids are reporting it's available. Now about 20% of kids say that they could get heroin easily or very easily. This is a population prevalence. I just want to cover some other drugs real quick. So marijuana use, percent using marijuana in the past month. This is 18 to 25-year-olds. We see rates of 15 to 20%. And then, and this is past month use. This slide, just to try to make it clear, monitoring futures past year, right? So past year use. So past year use is going to be higher than past month use. So past month's use by 18 to 25-year-olds is somewhere between around 18%. Among 17-year-olds and under, we see rates of about 7%. Past month's alcohol use actually tends to steadily decline. So in 2016, about a third of 12th graders reported that they used alcohol at least at one point, 20% of 10th graders and 7% of 8th graders, and that's on the decline. What we see among binge or heavy alcohol use, binge use is somebody that within the past month said that they drank 3 or more drinks I'm sorry, 4 or more drinks on one occasion. And a drink is defined as a standard drink. I'll kind of get into standard drinks in a second, but so that counts as a binge, and heavy alcohol use is 3 or more binges a month. So that's considered to be heavy. We know for underage alcohol use that there are 7.3 million current alcohol users. This is sort of for all adults, but we know that cigarette use continues to steadily decline. So we've seen a big drop due to a lot of public health messaging from like 1996 to 2016 over the past 20 years that this survey was published. Looking at pretty big drops in conventional cigarette use, but that has been accompanied by huge increases in vape use. So there's a lot more kids now smoking vapes and electronic cigarettes than smoking conventional tobacco cigarettes. This is a slide on the opioid epidemic, just looking at the concordance between sales, death, and treatment. So these are sales by kilogram of prescription opiates, deaths per 100,000 people due to prescription opiates, and treatment admissions related to prescription opiates. So what I'm about to get into is what I just mentioned before, which is set and setting make a big impact on how addictive a substance is. It has just as much to do with how the molecule affects the brain as it is the context in which you're using that molecule in the first place. So when you use, you get intoxicated. This saturates your brain receptors, which give you relief and pleasure. But when the drug levels drop, you crave it and then use it again. And the more cycles of this you go through, the more your brain learns an addiction. These are the brain areas thought to be responsible with that. So binge and intoxication effects are thought to be mediated by the striatum, ventral tegmentum, the cerebellum. We know withdrawal and negative affect is your amygdala. And then your preoccupation and anticipation and searching for more drugs is your prefrontal cortex and your hippocampus, which is where your memories are stored. So this is the non-addicted brain. You have an event, then you want to go use drugs, but your frontal cortex says, nope, we're not going to go do that, so you don't. Versus somebody whose frontal cortex is not functioning appropriately. Let's say you walk into a bar or you walk on a street where somebody that sells you a drug usually is, and the part of your brain that says, I don't know that drinking or using is that good of an idea is not functioning, but your memory says, remember how good that felt? We got to go use, you go use. So this is thought to, a very kind of simplistic model that compares addictive brain function to non-addictive brain function. And there are a set of clinical criteria that are used to define when does it count as a substance use disorder. And what's interesting about these criteria is that these criteria do not depend on the amount that you use. You could be drinking very little and meet use disorder criteria, or drinking very heavily and not use disorder criteria, right? So it's defined by how the drug affects you, not just how much drug you're using. So a substance use disorder is characterized by you're failing to fulfill your role obligations. You're not showing up to work, you're not showing up to school, you're not showing up as a family member. Use in situations in which it's physically hazardous. Anybody that's using IV, I count as using in a physically hazardous way. You're continuing to use substances despite recurrent problems. You might experience tolerance or withdrawal of the substance. You're taking the substance in larger amounts over more time than you initially intended. You are having a hard time cutting down. You're spending a great deal of time using. You're giving up activities due to substance use, and you're using despite recurrent problems and craving. So these are the 11 criteria. If you meet 2 or more of these criteria, you have a substance use disorder. 2 to 3 counts as a mild. 4 to 5 counts as a moderate, and 6 or above counts as a severe use disorder. There is another definition of addiction that's promoted by the American Society of Addiction Medicine. ASAM defines addiction as a primary, so it's not due to something else. It's not because you're depressed. It's not because you're anxious. It's not because of your personality, but it is a primary disease, medical condition that goes into medical history, not social history. Chronic disease of brain reward, motivation, memory, and related circuitry. And dysfunction in these circuits leads to biological, psychological, social, and spiritual changes. And this is reflected in people pursuing reward and relief by substance use and other behaviors. It's characterized by an inability to abstain from using, impairment of behavioral control, craving, diminished recognition of significant problems, and dysfunctional emotional responses. Like other chronic diseases like hypertension or diabetes, it often involves cycles of relapse. So there's this idea of, wait, we'll send you to treatment, and when you come out of treatment, you're fixed. I will tell you that for most chronic conditions, if you have high blood sugar and I give you insulin, your blood sugar will go down. But if I don't keep giving you insulin, then you're going to go right back up to where you were. Same with hypertension. If you have high blood pressure and I give you an antihypertensive, your blood pressure is going to go down. But if you don't keep taking the antihypertensive, your blood pressure is going to come right back up. The same is true with addiction. I can send you to a residential program, and you're likely not to use during that 28 days or however long the residential program is. But the minute you come out, unless you are doing some ongoing treatment, maybe a medication, maybe not a medication, maybe it's therapy, but if you're not doing something for your recovery in an ongoing way, then you're likely to go back to using. So this idea of you go to treatment and you come back and you're fixed is actually a false idea because it's chronic and involves cycles of relapse and remission. So this is the part of the addiction cycle where most treatments try to intervene, particularly the medications that we have for substance use disorders start here at trying to mitigate craving. So when you give, let's say, somebody with tobacco use disorder, varenicline or nicotine replacement therapy, you are trying to mitigate their craving and they're using again. All right, this is where most of the treatments work. Now, one of the big tragedies in the substance use disorder field is that of the 90 million or so people in the United States that have a substance use disorder, we know that less than 10% actually get what I will call specialty evidence-based addiction treatment. So 90% of people that have a substance use disorder have untreated substance use disorders. And that makes substance use disorders a unique kind of disease to treat. Most people with diabetes or cancer or hypertension, they want to be treated for that. But most people with substance use disorders do not want to be treated for their substance use disorders. So the Surgeon General of the United States has this report, Facing Addiction in America. And in this report, he says, rather than expecting to change people's opinions, give insight, and build a better treatment system, we should, rather than expecting patients to go to treatment, we should bring treatment to wherever patients are. Consider family from the patient's point of view. Who would the patient describe as their family member? Because substance use can affect family members differently. And when thinking about family function and how do substances affect family function, if you have a patient and they're a child, they might be affected by a substance use disorder even if it's not their substance use disorder, right? You know what I mean? Like a family member who has impairments. So one way of looking at family is to look at, well, what's the effectiveness of the way families communicate? How support or opposition are family members? What are the parenting skills present in this family? What is the conflict management, and what's their understanding of substance use disorders? And when the patient themselves, like let's say the teenager who's using substances, these are important flags to consider when trying to work with a family that might have an identified patient. I want to talk just a second. I know this is going to sound wonky, but I think it's relevant. There are different ways that family members attach to each other, different styles. So one style is avoidance. If there's anything wrong in the family, the parent or family member ignores it, right? And the more extreme the dysfunction, the more avoidance and ignoring goes on. Versus, so that's high avoidance. Low avoidance would be a very confrontive family member that's immediately involved in anything that's going on in their family. And there's different styles of anxiety. There are certain people that are absolutely unflappable. They don't feel any anxiety at all. Like there could be, like the world could be on fire and they're just like sitting there, right? No problem. Versus very high anxiety styles of attachment where people are, very reactive and very anxious. So low avoidance, high anxiety parents, those are what are called a preoccupied attachment style. These tend to be parents who are like helicopter parents. They're very preoccupied with everything that's going on in their child's life. Fearful avoidant are people that are really fearful but also very sort of avoidant of any problems or any conflict in the family. And then there's dismissing avoidant people that are like, that's not a problem, not relevant, just kind of checked out, not particularly connected. So that's a dismissing attachment style. And so the secure attachment style, the attachment style that's thought to be most helpful for children that are developing, is a low avoidance, low attachment style called secure attachments. The reason I bring up attachments is that dysfunctional attachments, these these quadrants right here, are associated with a higher risk of substance use disorders in the kids, because those are kids that oftentimes learn to use substances to substitute for psychological needs they might not be getting from their family members. These three, preoccupied, fearful, avoidant, and dismissing avoidant, are the three attachment styles that are thought to raise kids with a greater risk of a substance use disorder. When I say risk, it doesn't mean you're going to have a substance use disorder. It just means you have there's a higher rate. Because it's people that sometimes learn to use substances in place of secure parenting styles or secure attachment styles. I would say parenting, like families are complicated, and parents aren't the only entities that have an effect on their kids. Other family members, siblings, all of these can have an effect on kids. But these are what are called classically described attachment styles. So the Surgeon General report said, well, look, not everybody is at equal risk of a substance use disorder. Risk factors are early initiation or exposure to a substance, persistent problem behavior, rebelliousness, favorable attitudes towards substances, pure substance use, and genetic predictors. These are thought to be the major individual risk factors for adolescents. But there's also family risk factors for adolescents, like family management problems, family conflict, parental attitudes promote substance use, and a family history of substance use are also risk factors for substance use disorders. And then there's school risk factors for substance use disorders, such as academic failings beginning in late elementary school and lack of commitment to school. There are also community risk factors related to substance use disorders, such as if alcohol is widely available and low cost. One of the big public health interventions is limiting the proximity of liquor stores to schools, right? Because the more alcohol is available and the cheaper it is, the greater the rate of alcohol use. High availability of substances in general, big risk factor. Community laws and norms favoring substance use. Media portrayal of alcohol use, low neighborhood attachments where neighborhoods don't feel connected to each other, community disorganization, low socioeconomic status, and transitions and mobilities as communities that that are always in transition and nobody sort of stays in them for very long. Now, there's also protective factors. So we talked about risk factors, but actually social, emotional, behavioral, and cognitive and moral competence is thought to be a big protective factor. People that feel efficacious. Spirituality is a big protective factor. And just overall resiliency is thought to be protective against substance use disorders. Opportunities for positive social environment, recognition of positive behavior, bonding, marriage or committed relationships, and healthy beliefs and standards are family, school, and community protective factors. So there are things that you can build into, say, a person, let's say build into a person, that's a funny way of putting it. There are factors that people can have, there we go, that protect them against some of these risks, right? So it's not that everybody with risk factors is going to develop a substance use disorder, but there's a balance between risk factors and protective factors. So these are the policy implications that I would suggest, is an ideal policy regarding substance use disorders limits intoxicant access to 21, or if we're going to follow the science, like 25. Keeping youth engaged in school, providing schools with resources so they can identify and help students who are using substances, and community-based intervention systems to evaluate youth under the age of 18 who are using substances problematically, and providing educational and constructive interventions, including professional treatment, to youth who have a substance use disorder. And there's a study that came out, this is a Macaulay study in 2016. I want to highlight, this was a small sample that there are some, what's the term? Methodologic issues with this article. But one of the reasons that I think is interesting is in this context, dentists perceive that patients already know that education, already know about opiate prescriptions, or that education was not needed for short-term opiate prescriptions. And these are general dentists, not specifically pediatric dentists. They perceive a low risk of abuse and diversion among their patients, and the majority of dentists reviewed abuse and diversion as being not too much or not at all among patients in their practice, although the same number of dentists also said that they've refrained prescribing opiates in the past due to suspected diversion. So there is overall this thought among a small group of dentists that were surveyed. I don't mean to suggest this was widespread, but among a small group of dentists that were surveyed, that opioid use disorder is uncommon and that most people understand around the risks of opioid use. So I want to offer a framework for identifying patients that might not be using substances appropriately, because that's a really important risk factor for whether or not somebody's going to do well if they're exposed to opiates or not. There is, on drugabuse.gov, which is the National Institute on Drug Abuse website, a whole bunch of screening tools that you can use stratified by substance type, patient age, and how it's administered, that you can use in clinical practice. These are built for primary care, but they're not exclusive to primary care. questions you can ask to screen for substance use disorders. This is the screening to brief intervention. You ask, in the past year, how many times have you used tobacco, alcohol, or marijuana? If somebody says never, you're done. But if they say anything other than never, such as once or twice monthly or weekly, then you continue and ask prescription drugs that were not prescribed to you, such as pain medications or Adderall, illegal drugs such as cocaine or ecstasy, inhalants such as nitrous oxide, and herbs or synthetic drugs such as salvia, K2, or bath salts, right? And then that can give you information about whether or not somebody is using substances illicitly. Does not mean that they can't get an opiate. It just might mean that that person might need a shorter duration of opiates and closer follow-up visits. This is the BSTAD, which is another tool on the to evaluate risk. These are not diagnostic tools, these are screening tools to help you categorize which of the people that are at risk, more risk, and which of the people are at less risk. So the BSTAD asks, do you have friends who smoke cigarettes or use tobacco products? Do you have friends that consumed alcohol in the past year? Do you have friends who sniffed or huffed anything? Took illegal drugs like marijuana or cocaine, although we'd have to amend this in California to be like marijuana or illegal drugs like cocaine, took prescription medications that were not prescribed to them, or took prescriptions or over-the-counter medications more than they were supposed to take. And have, in the past year, have used cigarettes or other tobacco products. Have you used beer, wine, or any drink containing alcohol, and have you done any of these behaviors? And then you ask which of the substances you have used. This particular tool separates out marijuana, cocaine, heroin, amphetamines, hallucinogens, and inhalants. And then prescription pain relievers, sedatives, prescription stimulants, and over-the-counter medications. And then it asks about 30 days, 90 days, and past year use. Okay. This is the CRAFT. This is the classic alcohol screening tool for adolescents. Have you ever ridden in a car? Did you ever met somebody who was high or been using alcohol or drugs? Have you used alcohol or drugs to relax? Do you use alcohol or drugs by yourself or while you're alone? Have you ever forgotten things while you're using alcohol or drugs? Do your family or friends ever tell you you should cut down on your drinking or drug use? Have you ever gotten into trouble while you're using alcohol or drugs? So that's the CRAFT. So those are some three screening tools. Screening to brief intervention, S2BI, can be administered online. So it can be administered in a waiting room if you have like a tablet or something. And this is a pretty good guide that I like, published by the National Institute of Alcoholism and Alcohol Abuse, called Alcohol Screening and Brief Intervention for Youth, that looks at on how many days in the past year did you drink and stratifies based on their age which use pattern is considered to be high risk, moderate risk, and low risk, right? And so, and you estimate risk levels by age and frequency. For lower risk, you sort of affirm low drinking levels. For moderate risk, you offer some brief advice, and for highest risk, you evaluate whether somebody has an alcohol use disorder and considering arranging treatment. And when it comes to doing a brief intervention or offering some brief targeted advice, particularly with adolescents, I can't remember the last term I ever asked if anyone wanted to quit something or stop something. So there are, I don't mean to, what's the right term, shock you, but there are adolescents in your practices that smoke marijuana. It's true. And it's true. And so one of the ways that I would not deliver a brief intervention would be, you need to stop smoking, right? Because they might say something like, sure, fine, whatever, but you're not eliciting from them anything that is useful or helpful. So what I will sometimes say is, have you ever thought about changing your marijuana use? And they might give me this look. What do you mean by change my marijuana use? And I was like, yeah, like have you ever thought about like doubling or tripling the amount that you smoke? Like, buying a like scuba gear so all you're doing is breathing in like marijuana and smoking all the time. And oftentimes they laugh and then they say, well, no, I'm not, no, I don't want to double because it's too expensive. And I know it's probably not good for my lungs. I don't want to be high all the time. And now what they're doing is giving me the reasons why they don't want to smoke more. So then I'll turn it around and say, okay, it sounds like you don't like how expensive marijuana is. You may not like the way it affects your breathing. You may not want to be high all the time. Have you thought about cutting down? Right? And then do something like a confidence ruler or readiness ruler. We'll ask, well, on a scale of 0 to 10, how motivated are you to cut down your marijuana use? Because cutting down is a much softer way of asking about change. So I'm not starting with, are you ready to quit or stop? but I'm starting with change, which could be anything, right? So change is a much lower threshold term. And then if I say on a scale of 0 to 10, how motivated are you to cut down? They might say, oh, I don't know, I'm a 5. I'm kind of in that middle range. Part of me wants to, part of me doesn't. So then I'll say, well, what makes it a 5 and not a 2? Because the next thing they'll say is why they're interested in quitting. The other thing I might say is, if you were to cut down, how would you do it? A brief intervention usually lasts 3 to 5 minutes. It's not that long, but structuring the conversation where it's the patient that's giving you the reasons why they might want to cut down is the best way to do it. Rather than me trying to think, well, you know, smoking's bad for your this, and it's bad for your that, and this oral cancer, you know, if I'm doing all the work of coming up with all the reasons why somebody might want to stop, they're just going to stop listening to me, right? Because they don't resonate with those reasons. I don't know what reasons they're resonating to. I want to structure the conversation such it's the patient that's giving me the reasons why they might want to make a positive change. And every once in a while, I have a patient that says, I smoke all day, I smoke every day, I love everything about marijuana. If I had more money, I would smoke it all the time. And in which case, I accept that that is their position, and we don't talk about it. I might offer some brief advice, like, okay, is it okay if I offer you some advice? So I'll do something called the ask, tell, ask. Is it okay if I give you some information? And if you ask, people will usually say yes. Yeah, sure. Say, okay, whether or not you smoke is up to you. You know, you can walk out of here and smoke as much as you want. In my experience, people that smoke all the time don't always get the things that they want in their life, right? Because it distracts them from other ways of expressing themselves, and oftentimes marijuana leaves people a bit more cloudy and can have long-term health effects. However, what you smoke and how much you smoke really is your decision, and I just want you to know that I'm here to talk to you if you have any questions about my thoughts about smoking. What do you think you might do? That's an ask, tell, ask. So you can still give information, right? So the strategy of trying to elicit change talk is not always successful, and sometimes I'm left giving a directive, but I'm giving a directive not as somebody who can control whether somebody uses or not, because people are going to use whatever they're going to use, right? That's not something I can control. But the directive would be, you can do what you're going to do. My recommendation would be consider X, but again, affirming their autonomy. But you know, you have autonomy here, so what do you think you're going to do? Is the best way of structuring giving information rather than just giving unsolicited information. And that moment of saying, is it okay if I give you some information, sounds perfunctory. Like, why would I need to do that? They're here. They're in my office. Of course, they're here to listen to me. Creates this window that they might actually listen to you, right? Like asking permission creates this opportunity. Somebody might actually take in something you're going to say, as opposed to what I have seen many clinicians typically do, which is da 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 da, and then they leave, and then the patient's sort of left like, okay, wait, what did they say? And we know, looking at things like medication adherence, that simply giving somebody instructions works about 50% of the time, and that there's about 50% of our patients walk out and don't do everything we say. So of these two clinicians, which clinician do you think is employing a style that's closer to a motivational interviewing style? Is it clinician A or clinician B? B. Why? Why is it B? Uh-huh. Well, I will say one thing. Who's doing the talking? She's doing the talking. Who's doing the talking here? If I can get the patient to do the talking, that's gold. If it's about change talk, right? I can't just have them ramble, right? Like I, appropriately focus the conversation, usually with very pointed reflections, like, oh, you smoke a lot. That's a reflection. And then they'll start talking about smoking. Okay. And then I might ask an open-ended question like, have you given any thought to changing your smoking? And most people that smoke tobacco are not enthusiastic about smoking tobacco. A lot of people that vape really like vaping. And a lot of people that smoke marijuana or use cannabinoid products are very enthusiastic about those things. So using reflections that open-ended questions to try to elicit somebody's interest in change oftentimes can be very effective, particularly when it's the patient that's the one who's doing the talking. Okay. So the other tool we have to identify whether somebody has a substance use disorder, I should misstate that, whether somebody's been using substances, which they may or may not have a substance use disorder. But one way of finding if somebody's been using substances is toxicology testing. And toxicology testing is typically done with urine. That said, there are alternative fluids you can test, and dentists know all too well. Saliva is a perfectly testable fluid for substance use, to detect recent substance use. The detection time frame in saliva tends to be shorter duration than that of urine. One of the beautiful things about urine is urine concentrates intoxicants. That's what the kidney does. Is it takes toxins from the blood, puts them in urine, right? So if you're looking for a fluid, what are all the intoxicants you've been taking? Well, the kidneys have done that work for you. They've surveyed all of your bloodstream and pulling out the substances for testing. I mean, for excretion, but you can test them. So saliva just doesn't last the intoxicants don't last as long. Blood is not the recommended tool for detecting intoxication, with the possible exception of if you're coming into the ER drunk, that will give you an alcohol level at the point somebody comes in. You can also use a breathalyzer, but I rarely use blood outside of an acute setting like an emergency room. And you can test hair, but one of the problems with hair is it's a very expensive test. It takes a long time to come back, but it will tell you what substances they've been using for like 3 months, depending on the length of the hair. I cut my hair every like 2 weeks, so you got 2 weeks. Sweat, you can test, and that's like a 14-day, and nails give you anywhere between 7 days to 3 months. Breathalyzer really only works for alcohol and carbon monoxide testing. So carbon monoxide testing is one test you can use to see if somebody's been smoking things. Let me be clear, smoking things includes cigarettes, smoking things includes marijuana. You can, smoking things that were ignited, right? That's what carbon monoxide testing will tell you. Cotinine is the actual molecule for nicotine. So the gold standard, if you want to see if somebody's smoking, is to do both a carbon monoxide test and a cotinine test. Because you can smoke marijuana, still have lots of carbon monoxide, but not be smoking cigarettes. So that's what a saliva test looks like. What you do is you take the swab, soak it in the mouth until it's saturated, then put it in this immunoassay box. You can draw blood, that's what that looks like. Or you can put it in a breathalyzer. And these are what the strips, I'm going to go back. See these strips on the cup? The way these strips are built is they're built with 2 lines. And one of the challenges with immunoassays, because they all pretty much work the same way, is 2 lines is negative, 1 line is positive, which drives me nuts. Because in most other testing, the additional line tells you it's positive. In pregnancy tests, it's 2 lines, right? But in drugs, in substance abuse, it's the test line that disappears if the test is positive, right? So the sample goes here. You get a conjugate, you get a pad release, and I'm not a chemist, so I'm just going to say through the magic of immunohistochemistry, the test line appears if the test is negative and disappears if the test is positive. The control line appears if it's urine and disappears if it's not. Water, bleach, whatever people adulterate their, or try to put as urine. And the wicking pad sucks the fluid up. So this is kind of the chemical suction that sucks it through here that gets you the conjugated pad release and the test line and the control line. So 2 lines is negative, 1 line is positive. You can also send a test. And those are for, just to go back, these are for tests that look like this. These are convenient because they're point of care. One of the things that's not good about these tests is there's an error rate. So I'll give you a couple examples. There's a strip for benzodiazepines. If you want to know if somebody's taking benzodiazepines, the strip for benzodiazepines is notoriously poor at detecting lorazepam, which is Ativan, or clonazepam, which is Klonopin. It's pretty good at Xanax and Valium, right? And decent at Librium. The cocaine pad is almost never wrong. Cocaine is almost always the most accurate immunoassay we have. And the opiate tests will only usually test codeine derivatives. So if you want to know if somebody's been taking oxycodone, or in morphine and codeine derivatives, so like things like hydromorphone, hydrocodone, codeine, any of those things will come up on an opiate test. But it won't detect oxycodone, which is a thebaine derivative, semi-synthetic version of thebaine. And it won't test for methadone or buprenorphine or fentanyl. So if you really want to test for opiates, you should be running 5 tests. Morphine derivatives, oxycodone derivatives, methadone, buprenorphine, and fentanyl. Okay. So, but if you want to know specifically, right, these are screening tests, give you an idea of whether it's positive or negative or not, but it's not definitive. If you want to send for a definitive test, those are all run at labs. You have to send a sample to the lab. It can't be done in your office unless you want to buy. These machines are about $100,000. And you actually put in the sample, and then it runs it through a gas chromatography column, and then actually gives you not just which chemicals were in the sample, or chemicals of interest, but at what amounts. So it gives you a quantitative confirmatory test. So presumptive immunoassay screening is useful because it's routine and not that expensive. And it should be used when you want to have a priority, like a more immediate result, but the accuracy is less important. A definitive test is conducted when a patient disputes the screening, is expensive, can be used to confirm or refute the screening test, and can quantify a very specific substance. Which substance you collect depends on things like the duration. So ethanol tests only last in the system for less than 12 hours. So if you want to see if somebody's been drinking, you test for ethyl glucuronide and ethyl sulfate, which is in your system for 3 to 4 days after your last drink. And then barbiturates, the longer acting the drug, the longer it stays in your urine. So barbiturates, it's 2 to 4 days, except for phenobarb, which is 2 to 3 weeks. Benzos are 24 hours for things like alprazolam and lorazepam, 2 to 4 days for things like diazepam, clonazepam, and then 7 days for chlordiazepoxide. And then cocaine is in your system for 6 to 8 hours, but the benzocaine is in your system for 2 to 4 days. And that's what's tested in the cocaine test. LSD is 2 to 4 days. Marijuana, it depends on how long you've been smoking because marijuana stores in your fat. So if you're an all-day, everyday smoker, it stays positive for a month. 2 weeks if you use pretty consistently for days, and then 3 to 4 days after one use. MDMA, which is ecstasy, is in your system for 2 to 4 days. Nicotine is positive for 12 hours. And then your opioids, codeine is positive for a day or two. Buprenorphine is for 2 to 3 days. Heroin, hydromorphone, and morphine is 2 to 4 days. And methadone, anywhere from 2 to 3 days or almost over a week if you're on methadone maintenance. So the rule of thumb for opioids, if that's the substance you want to test for, is typically 2 to 4 days for most things that are prescribed. There are false positive results on immunoassays, so I don't want to say if you're trying to do screening for substance use disorders in your screening for substance use in your practice, that the immunoassay test will always be positive. And this is from a pretty good article called Urine Drug Screening, Practical Guideline for Clinicians. And let's say that somebody is identified to have a substance use disorder. And let me speak broadly: tobacco use disorder, alcohol use disorder. It could be your patient, it could be the family of the patient. The core components of addiction treatment are counseling, support, and medications. And most people think, I should say not most, but a lot of people think, oh, if you have an addiction, go to meetings, go to 12-step meetings, go to Alcoholics Anonymous, and that will help you. Alcoholics Anonymous is a wonderful support, but it is not counseling, and it's not a medication. The thing with addiction, though, is that not all addictions are equally responsive to counseling, support, and medications. Opioid use disorders are notoriously difficult to treat with counseling and support, and medications can have a really big role. For stimulant use disorders, there are no medications available, and all we have is counseling and support to treat, say, amphetamine use disorder. I use the term medications for addiction treatment rather than medication-assisted treatment to refer to the handful of medications that have been FDA approved for the treatment of substance use disorders, because I think that medications are a treatment. Just to go back a slide. These are the three components. One component is medications. So I don't think of medications as being somehow not as effective or not a component of counseling and support. And that's why the term medication-assisted treatment is weird to me. Like, we don't talk about medication-assisted anesthesia. Like, the medicine is anesthesia. You know what I mean? Like, we don't talk about medication-assisted depression treatment. Like, antidepressants are a treatment for depression. So I'm adopting the same terminology in addiction medicine, which is medications for addiction treatment. And there's actually only 8 molecules that have been FDA approved for the treatment of a substance use disorder: methadone, buprenorphine, naltrexone, disulfiram, acamprosate, nicotine, bupropion, and varenicline. That's that. Now, there's a couple different formats, right? So buprenorphine comes in like 7 different medication formats at this point. I think 9 if you include the ones for pain. And naltrexone comes in 2. There's an oral pill and an injectable. But these are the FDA-approved molecules. And nicotine comes in 5, right? So there's the nicotine patch, gum, lozenge, nasal spray, and inhaler. Just really quickly, I do want to cover how these work, not because the expectation is that pediatric dentists are going to be prescribing medications for addiction treatment, although I think you can prescribe the ones for tobacco. But there are patients who are on maintenance treatments for opioid use disorder that you're going to run past in dental practice, and you should have some general idea about how these work and what to do. So the way that methadone works for opiate use disorder is it saturates your opioid system. You get the dose high enough that you become so tolerant to opiates that you don't feel opioids anymore, right? And so when somebody comes to your practice on opioids, you can still use a full agonist opiate on top of methadone to treat somebody's analgesia, but they're going to be opiate tolerant. Buprenorphine is unique because it has a high affinity at the opiate receptor, but only partially activates it. So you get a lot of the benefits of being on something like an opioid antagonist because it's going to block the effect of other opioids, but and when I say blunt the effect of other opioids, it's not a full blockade, but it sort of blunts it. But you only get a partial activation of your opioid system. And then naltrexone is an antagonist of the mu-opioid receptor. And Narcan or naloxone is also an antagonist. The big difference is naltrexone's a pill and naloxone's an injection, right? So or a nasal spray. But this is not active, medically active orally, whereas this is. And so this just illustrates that. Like methadone, you get full opioid activation. The higher the dose, the higher the effect. If you give somebody too much methadone, they stop breathing. It's relatively straightforward. With buprenorphine, on the other hand, it's almost impossible to overdose on it if you've been exposed to opioids. So with buprenorphine, you only get this partial agonism. You have this what's called ceiling effect. And Narcan or naloxone or naltrexone are simply antagonists. The higher the dose, the more the blockade. Opiate medications are effective and necessary to treat acute pain in people who are on buprenorphine or methadone. So if somebody is on maintenance and you're doing, say, like an extraction or surgery where you anticipate pain, you can actually recommend that their prescriber continue the buprenorphine. Do not reduce the dose. And if the pain is thought to be mild, they can actually increase their buprenorphine dose to get some additional analgesia. You want to maximize non-opiate analgesics and regional anesthesia. And if you can give somebody on buprenorphine a brief is usually days, trial of full agonist opioids at higher doses than you would have otherwise thought because they're opiate tolerant, right? So somebody comes in on buprenorphine, you can coordinate with their prescriber to keep them on the buprenorphine and use slightly higher, like instead of oxycodone 5 to 10, consider 15 to 20, higher doses of, say, a PRN, brief supply, few days supply of opioid analgesia while somebody's recovering from whatever the dental procedure was. For methadone, not dentists don't prescribe methadone for it, but one can split methadone into TID dosing, right? So if they usually get 90 milligrams a day, they can get 30 TID. They can help provide some analgesia. And the patients are opiate tolerant, so use short-acting opiates briefly, and keep in mind methadone is a risk factor for sleep apnea. Now, if somebody's on an antagonist treatment, like long-acting injectable naltrexone, you can try, so it's a full antagonist. For mild to moderate pain, use regional anesthesia. If you try to use opiates and somebody's coming off of naltrexone, keep in mind naltrexone pharmacologically blocks any opioid tolerance. So you want to use low dose in anybody that's coming off of naltrexone. And in severe pain or in a planned surgery, you try to discontinue the naltrexone and then kind of gently introduce opioids. So that's how one does pain management in people who are on methadone, buprenorphine, and naltrexone. When somebody has a possible history of opiate use and they are found down, I just want to cover real quick. Opiate overdose looks like a weak thready pulse, slower absent respirations, constricted pupils, and weakness and unresponsiveness. We don't see a ton of this in the doctor's office, but you know what? Anything is possible. And so the difference between really high, which is relaxation, slowed speech, sleepy looking, and people responsive to stimuli, versus an overdose, which is pale chymiskin, no breathing, deep snoring, and not responsive to stimuli. These are thought to be how you make the distinction. This is what the overdose looks like. So if somebody's found down, this is what Narcan looks like. I recommend prescribing Narcan to patients that are at risk of opioid overdose. And in fact, it's now state law that anybody that's prescribed an opioid and a benzodiazepine needs to be prescribed Narcan. anybody who's on any opioids over 90 morphine equivalents, or anybody who has any history of a substance use disorder, and the way this law is written, tobacco use disorder, I guess, counts. So any substance use disorder and is being prescribed an opioid needs to be prescribed Narcan. Now, I don't think this law is written super well. I don't think this law is like well operationalized, but that's the law. And so this is what Narcan looks like. This is the 4 milligram spray. This comes with 2 in the pack, and the whole pack costs about $75. These generic vials of Narcan, they're liquid. This vial is about $1. And then the applicator and the nasal atomizer is also just about another $1. So you're looking at, $2 versus $75. But insurance covers this now. The way that it works is you assemble, this is the kit that's not the pre-assembled Narcan. And it is an antidote for opioids. So if somebody's ever found down, and this is something you want to tell parents, right? So if anyone's found down and you think it could be related to opioids, assemble this and spray it into the nose. It's not breathed in. They don't actually have to be breathing. The Narcan is absorbed through the nasal mucosa. It takes 8 minutes to work and lasts for 30 to 90 minutes. When I say it lasts for 30 to 90 minutes, your body metabolizes the Narcan. And whatever opioid they had on board that caused the overdose, that opioid will stay on board. So that's why if you give somebody Narcan and they are revived, they should go to an emergency room to get more Narcan, right? Because otherwise they're going to go back into an overdose. It's safe and effective, can be given through an IV, can be given intranasally, it can be given into the muscle. So, however, but it does not work orally. And it's carried by paramedics. It's a mist that goes into the nasal mucosa. That's how it's absorbed. They're not breathing it in. What I recommend to people who are being prescribed Narcan, and the reason I tell you is because as opiate prescribers, you're encumbered by state law to know about how to prescribe Narcan, is when I tell people is to use the whole vial, half up one nostril, half up the other, and you start seeing results within minutes. So you go from not breathing to breathing, blue to normal, level of consciousness improves, and somebody might be nauseous and have diarrhea. Anytime that I administer Narcan, which I have only done trainings on but have not yet had a chance to do it in the field, you always want to call 911 because that's the backup for who can manage an overdose. EMS can assist in breathing. If the heart is stopped, they can help with that. If they're not in cardiac arrest, they can administer more Narcan, and almost 100% will need transportation to the hospital. The longer somebody's in cardiac arrest, the closer is they're not going to ever come back. And long-term oxygen deficits cause brain damage that range from mild forgetfulness to severe. Narcan is not administered into the heart. I think there's, just to be really clear, if for anybody that saw Pulp Fiction, when John Travolta hit Uma Thurman in the heart with a syringe, what they were administering was epinephrine because she was in cardiac arrest from a cocaine overdose. That was the setup. I do not recommend doing intracardiac epinephrine injections in the field. It does not require extreme force. You do not see combativeness with intranasal admission. The most side effects is confusion, and the goal is to take them from dead to not dead. Okay, and if it's not working, they may have been out too long, or if somebody's overdosed, it might not be an opiate, right? Like some alcohol or benzos or sedatives or other things. So Narcan only works for opioids. Doesn't cause harm, but so that's a bit about Narcan, and now you know how to counsel your patients if you were to prescribe Narcan to them. And then really quickly, there are 3 medications that are approved, FDA approved for alcohol use disorder. Naltrexone, which is also FDA approved for opioid use disorder, acamprosate, and disulfiram. These all are thought to reduce cravings for alcohol. Disulfiram works by irreversibly binding to the part of the body that metabolizes acetaldehyde. Okay, I do want to talk a bit about medications for tobacco use disorder, which is something I think is pretty core to dental practice. Nicotine replacement, bupropion, and varenicline. I'm prescribing a patch to help you quit smoking. Wear it over your mouth. All right. So the patches comes in 7s, 14s, 21s, and 28s. You put it on the skin. It produces a steady nicotine level. I tell people to put it on in the morning and take it off at night. It can cause skin irritation. I ask people to have gum by the bedside if they wake up early. The patch comes on after the shower, and it can come off easily with sweat. So either if somebody goes to the gym, they either wrap it in tape or they bring an extra patch. And it's recommended to combine the patch with the gum or lozenge. The gums and lozenges comes in 2s and 4s. The way that it works is it absorbs through your cheek. So nicotine gum does not work if you chew it. It works if you chew it until you taste pepper, push against your cheek, then it absorbs. You can also do inhalers, which causes some nasal irritation, nasal sprays and inhalers for people that don't respond to patches, gums, and lozenges. You can add bupropion, which is an antidepressant that also reduces smoking behavior. It's contraindicated in anybody that has a history of seizures and anybody with uncontrolled bipolar disorder. You could combine with nicotine replacement therapy. And then varenicline. Varenicline is a oral pill. You take it twice a day. It blocks nicotine receptors but slightly activates them. You start at half a milligram once a day, then half a milligram for the first 3 days, then half a milligram twice a day for the rest of the week, and then 1 milligram twice a day. Again, it's a mildly activating drug, so you get mild activation of your nicotine receptors, but it blocks the nicotine from working. So I'll give you an example. I had a patient that I was prescribing varenicline to, and she went from smoking like a pack a day to like 3 cigarettes a day. It didn't make her quit, right? She didn't go from like somebody that smoked heavily to somebody that stopped smoking. But it helped her cut down, and then from there, she was able to learn skills to keep cutting down. Now, varenicline had a couple FDA warnings on the black box around suicidal thoughts, neuropsychiatric effects, and increased risk of heart attacks and strokes. Those black box warnings have been removed. There is no association between varenicline and suicidal thoughts that's been demonstrated in higher quality studies. So in 2016, the FDA removed the black box. What I tell people is the risk of smoking around cancer, cardiovascular disease, and lung disease is so high. And the risk, even the published risk, of neuropsychiatric effects, suicidal thoughts, and the theoretically small increased risk of cardiovascular events is so small that the benefits of this medicine clearly outweigh the risks. That said, if you have suicidal thoughts, stop taking it and call me, right? So I don't say like you won't get the side effect. I'm saying that it's not significantly associated with an increased rate of those side effects compared to placebo. And this came from the EAGLES, right? Evaluating Adverse Effects in Global Information Study, high quality study, broad population, representative sample, not increased risk of neuropsychiatric effects. So it's, in other words, it is the safety profile of varenicline, although there is no medicine that is, ever 100% safe, but the risks of this are far outweighed by the benefits. So if somebody wants to take a pill instead of the patch, or they have tried the patch and it hasn't worked, then I recommend varenicline. And I always recommend combining forms of nicotine replacement therapy. So if you're going to use the patch, always use PRN gums or lozenges. If you use varenicline, always use PRN gums or lozenges. And if somebody wants an antidepressant or they're worried about weight gain, bupropion is a good medication to consider adding. Really, my hope is that because a lot of the dental sequelae is evident on people's teeth, the dentist can also take a role in making these medications for tobacco use disorder available. And then just real quick, sometimes I get asked, so we talked about these medicines for addiction, but isn't there other pieces to recovery? So yes, there's clinical things that you can do to help people in recovery. There's self-management tools, and there's non-clinical things. So these are, just to go back, the clinical evidence-based psychosocial treatments. CBT, motivational enhancement therapy, multidimensional family therapy. These are thought to be really helpful in adolescence, right? Families, CBT, and motivational enhancement. A lot of kids don't like to go to 12-step meetings. There are youth 12-step meetings, but they're not as robust or ubiquitous as the adult ones. And community reinforcement, disease management, and multi-systemic therapy tend to be less available to adolescents. So I think of these three as the main ones that are relevant for adolescents and children. And then for those that have never sent somebody to an addiction treatment program, it comes in different levels. So there's everything from detox to residential to intensive outpatient to outpatient services. And most people don't need detox. There's only 2 drugs that detox even treats: alcohol and opioids. And opioids can be treated on an outpatient basis. You don't always have to you don't really need to go to detox to treat opiate use disorder. I do think that alcohol use disorder, because it can be associated, alcohol withdrawal can be associated with seizures, can start in detox, but you do not detox from methamphetamine. You do not detox from ecstasy. You do not detox from cocaine. You do not detox from marijuana. Residential is a kind of place where you live and you get the treatment on site, and that's developed, and that can be delivered to anyone. And all these levels of care are available to adolescents. These are the 11 indicators of quality addiction treatment. Now, I'm an addiction medicine doctor, so I say things like you should go to a place that has an addiction medicine doctor. But these are the 11 criteria, and there's a whole resource on here to help families guide their way to find a treatment program. There is a national tool. The Substance Abuse Mental Health Services Administration has a treatment services locator. Go to findtreatment@samhsa.gov. You can give that to the patients of family members. And if you have a family member that has no insurance and has Medi-Cal and is a resident here in LA County, there's actually a substance use disorder system of care here run through the Department of Public Health called Substance Abuse Prevention and Control. They have a 24-hour phone number that any Medi-Cal beneficiary or uninsured client here in LA can call. There's a website if you want to look just what treatment programs are available in LA County. What's their capacity? This is the website. Again, it's run by the county, and I work for the county, so that's why I'm putting this up, for Medi-Cal beneficiaries and uninsured patients. Not all of these programs contract with insurance companies. So if you have somebody with commercial insurance, oftentimes they have to call their insurer to find out where do they contract with for substance abuse treatment services.
Most insurances required to give you some substance abuse support?
The question is, do all insurance carriers cover SUD services? The answer to that is not always. But most commercial insurances do, but they're not required to. However, if an insurer does cover SUD services, they're required to cover them at the same proportion of the rate as they cover medical services. So the insurers that do are supposed to have an adequate network. That said, I've talked to families that have been continually frustrated by some network adequacy issues, but I've rarely heard of anybody with a commercial insurance that really had no substance use disorder benefit. Question over there?
Yeah, does insurance cover for naloxone without prescription?
The question is, does insurance cover naloxone without a prescription? Your way to get naloxone, yes. Well, so no, sorry. Does insurance cover it? It has to be prescribed. Now, pharmacists, I think, actually are authorized now to bill insurance for dispensing naloxone, but in most cases, I'm prescribing it. Now, anyone can buy naloxone if a pharmacist has got the training to dispense it, but not all pharmacies or pharmacists even know that at this point. So there is still a big push, and this is why we get laws like the one that just passed for January, that everyone should be prescribing Narcan all the time. Because insurance absolutely covers it if a provider, such as a dentist or a physician or another prescribing provider prescribes it, and I think they can cover it if a pharmacist dispenses it. But for Medi-Cal, which is where the system I work, it's got to be a Medi-Cal provider that writes it.
Because where I went to school back in Maryland, the school required us to buy naloxone, and then the insurance wouldn't cover in the state of Maryland.
Yeah,
In California.
Yeah, the comment was, in Maryland, your experience was that you were required to have Narcan on site, but insurance didn't cover it. Insurance will cover it with a prescription. Some commercial insurances, I think, can cover it if the pharmacist has counted, a prescription. Otherwise, it's cash. There is a really good American Dental Association Practical Guide to Substance Use Disorders and Safe Prescribing that I would encourage you to check out. And with that, this is my email address. The ASAM annual meeting is in Orlando in April. The California Society of Addiction Medicine meeting is in Anaheim in September. And then the American Academy of Addiction Psychiatry meeting is in North San Diego in December. Dentists are absolutely invited to come to this as medical students, dental students, nurses, non-clinicians. And with that, I will wrap it up and see if anybody has any questions.
Yes, any questions for Dr.
So the case is 14-year-old patient, several molar extractions in the operating room, required, is on acetaminophen and ibuprofen for pain control, and it's not controlling his pain. This is a 14-year-old kid that drinks alcohol and smokes marijuana. Can we safely prescribe him opioids? So I'll say two things. One, I don't know everything about like his molar extraction, but that sounds like a painful, like it sounds like he's got a legitimate source for pain, right? And it sounds like you're maximizing other oral agents. I'm not sure if there's any other interventional things that are reasonable to do, like nerve blocks. Those can be pretty uncomfortable because if somebody can't feel their face, right? That becomes sort of hard to function. Right, and they're brief. So, can you prescribe opiates to somebody at high risk of?
I guess my first question is, we all feel uncomfortable prescribing opioids, so what's like the next step that we can do to help him?
Yeah, so what's the next step that you can do to help him? So there's a couple options. Now, I think that somebody that is in genuine pain should have their pain treated, and if it's severe, that opioids can be a part of that. It wouldn't be opiates instead of acetaminophen and Tylenol, which is the same thing, acetaminophen and ibuprofen, right? It wouldn't be instead of that, but it would be on top of that. If I was to prescribe this person opioids, and a 14-year-old, so I would stay away from things like tramadol or codeine. I might use a short supply, like something on the order of like 3 to 5 days, of a short-acting opiate, such as hydrocodone or oxycodone. And do things like keep the prescription really short and see the patient back as soon as was feasible. So ideally later in the week. To look at how they're healing and see how does their report of pain comport with how many opioids they used. And if they, like went through all their opiates in 2 days, like way heavier than prescribed, then no, you can't, like, then opiates are not going to become part, like, if this person can't safely tolerate opiates, then no, then they wouldn't continue to get opiates. But on the other hand, I don't think that a 14-year-old that drinks alcohol and smokes marijuana necessarily can't categorically get opiates. But I would keep the supply short, and I would see this patient back frequently.
What do you mean by short? Like,
3 to 5 days. I would depend it based on when I could see them. So if today is Friday and I had time to see them on Monday, I would give them enough for Friday night, Saturday, Sunday, and then for part of Monday, so 4 days. And then I would have them come in, and I would have them bring in everything that they didn't use. So if they don't bring any in, then I just assume they use it all. And so I might even write them for like a 5-day supply. And again, I would try to keep the dose as low as possible. So like 5 Q8 hours, so like 5 TID, right? But I wouldn't give like 20 QID, right? I would try to keep the dose as low as possible. And this is where, not being in child, I can't, 14-year-old, I presume 5 milligrams is kind of a standard dose for, but I would do whatever the usual kind of dosing conversion is for adolescents. But try to keep the dose as low as possible and see them back as quickly as possible. Does that help?
Yes. Any other questions?
What other questions? Yeah.
You mentioned.
Yeah. So the question is, you just said a short-acting opiate in this case, but didn't you say that longer-acting opioids are less addictive? So you generally want to stay away from longer-acting opiates in adolescence. So when I'm referencing longer-acting opioids, I think what I'm referring to are things like buprenorphine or methadone, which are much less addictive than heroin, oxycodone, but I wouldn't necessarily throw on like OxyContin or MS-Contin in a kid who is we don't know about his opiate history, but I'm assuming he's opiate naive. You always start with short-acting opiates anyway. And the idea is that his duration of opiate treatment is going to be brief. That's the hope as he heals from the molar extraction, so that he's not necessarily going to be on chronic opioids. If I did have somebody on chronic opioids, I would, well, one, try to taper them off, because why would they be on, like it doesn't make sense to be on chronic opioids. And then, and if I thought somebody had an opiate use disorder, then convert them to a long-acting opiate that is less addictive than like oxycodone. So that when I'm referencing, I really mean more as a maintenance treatment and less as an acute pain management treatment. In acute pain management, I think short-acting opiates are just fine. Does that help differentiate?
Any other questions? Okay, great.
Hey, thank you so much for your time and attention.
Yes, thank you so much.